A quick look at triage and continuous assessment in maternity. When we talk about a triage in a system, we're looking at a department that, as we expect, will often have more patients than clinical capacity. So we need to appropriately categorize patients and see them based on acuity. So a triage system sort of delivers appropriate care to each patient with correct level of urgency in the right order with the resources that are available in the most efficient way. What we want to emphasize with the triage system is that we are not going to see patients on a first come, first serve basis, but we're going to see patients based on how critically ill they are. So the most critically ill patients get seen first, because seeing patients on a first come, first serve basis over the years has been shown to increase morbidity and mortality. There are various triage systems that are in use. The Birmingham Symptom-Specific Obstetric Triage System is one of them. OTAS is another one of them, and MUSE is one of them. Most places will use OTAS and BSOTs as triage systems. MUSE can be used as a triage system, but the only problem with using MUSE as a triage system is that it doesn't give place for assessment of the fetus. So you could say that you're only checking observations for patients who come into your emergency area, and based on their observations, you're going to act. But you could be more sophisticated, and I'll get into that as I go on. So BSOT involves a completion of a standard clinical triage by a midwife within 15 minutes of attendance of the unit. So when a patient comes into your unit, there should be a triage midwife whose job is to triage everybody. That same person could be assessing the patients after triaging if you have a smaller unit. But if you have a big unit, then it's probably better for another midwife to be doing further assessment of the patient after the triage midwife has triaged the patient, so that you have an overview of the patients in your emergency area, how all of them triaged. Because if you have a big unit and there's just one midwife who's doing triaging and doing further assessment, you would have a lot of patients sitting there who would not have been triaged and who you do not know what is happening with them because you've taken no history. In the triage room, what the midwife would do is take a brief history, baseline observations, assess level of pain, abdominal palpation, and auscultate the fetal heart rate. In BSOTs, this is what we basically do. So based on the initial triage assessment, we decide where the patient's journey will lead to. If the patient has come in shock, maternal collapse, or a fit, or a massive hemorrhage, or severe pain, this patient should probably be going straight to your emergency area. So you should have a high dependency unit or a day surgery unit or to theater. Because if a patient comes in with acute fetal bradycardia, that's going straight to theater as a category 1. If a patient comes in as a massive hemorrhage, you're probably calling a category 1 cesarean section for an APH. Or if it's a PPH, you're probably heading to theater. If a patient comes in with a fit, you're probably heading to your HDU to try and assess this patient, give you max sulfates, stabilize this patient, and then head to theater. So in order to have an effective triage system, there should be a place to send these acutely ill patients. Now, patients who are categorized as red, it's not the color that matters, it's what happens that matters. If you're categorizing a patient as red, it means they need continuous monitoring. So there should be a monitor to put them on. They should be in a high dependency area or an observation area for you to keep an eye on them. And then you have your patients that will come in who will categorize as a yellow, as an orange, who patients with chest pain, shortness of breath, moderate continuous pain, moderate bleeding, active bleeding. These are also high-risk patients who need emergency care. And these patients should be on monitoring every 15 minutes. So these patients are also patients that you keep on assessing. You get somebody seeing them every 15 minutes. You want to assess the fetus and you want to take bloods to group and save, you want to take urine samples and get medical review within 15 minutes for these patients, because these patients can deteriorate very quickly and you need to act quickly with these patients. And you realize that in BSOTs, Muse has been incorporated into it. And so you realize later on that Muse can be implemented just based on scoring or just based on whether they have one red or one yellow or two yellows. So in incorporating Muse into BSOTs, if a patient has one red value, then they qualify as having an abnormal Muse and you categorize them as orange and need an assessment within 15 minutes. Now, it's not the orange that matters, it's what happens that matters. So if you categorize a patient as orange, then you should be monitoring them every 15 minutes. Now, if you want this to work, these patients should probably also be on some sort of a monitor that has been timed to work every 15 minutes. Because if you have a nurse who has to go and take a blood pressure cuff and come and check observations every 15 minutes, it makes it a bit difficult for this to be implemented. This patient will also need bloods taken, group and safe taken, and medical staff should be available to assess this patient immediately. Then you have your yellow patients who are patients who have to be assessed within an hour and have baseline observations done at least hourly. So these are patients with mild pain, normal fetal heart rate, reduced movement, scoring one yellow on their Muse chart. So this means for patients who are coming in, you are taking a basic history by the midwife and doing a complete assessment and doing a Muse assessment as well for these patients. And of course, you have your patients who are green, who can go back to the waiting area together with the yellow patients to be reassessed again in about 4 hours. So you also have to ask yourself, if you have a lot of patients coming through minimal pain, normal observations, normal heart rates, very little contractions, these green patients, are they patients who you can send to another area to be reviewed so that the patients in the emergency unit or the triage unit can focus on the severely ill patients? Or, I mean, you have to look at your capacity and the number of patients and decide this as a unit. So based on the categorization, you categorize your patients as red, orange who have to be assessed within 15 minutes, yellow reassessed within an hour, or green reassessed within 4 hours. And what you do when you're implementing BSOT is that you have a big board in your triage room where you know all the patients in the unit, patients who are in the waiting room, patients who have are being assessed, and patients who are waiting to be assessed, so that at a glance you know what you have. You know patients who have been assessed, patients who are waiting to be assessed, and of those who have been assessed, you can also tell patients who, when they've come in, how long they've been waiting, whether a midwife has seen them, and who has been seen by a doctor. And you know the categorization of the patients in your waiting area, and you know where they are in your waiting area. So at a glance, you have a situational awareness of what is happening in your triage, who is waiting, who needs to be seen by the most experienced person, who can be seen by a junior colleague in the triaging area. So having a board in the triaging area gives you situational awareness of what is happening around you. So essentially, red and orange patients have urgent care, yellow and green patients can wait and be assessed later within an hour or within 4 hours based on BSOTs. Now, there's also the OTA system, which categorizes patients into 5 categories as resuscitative, emergent, urgent, less urgent, and non-urgent. Now, OTA system also means a patient has to be triaged within 10 minutes of arrival. So again, you need a triage nurse who is triaging every woman who is coming into the system. And based on that triage skill, is handing that patient over to another nurse who is doing initial assessment and then getting a medical review. Again, if you're going to implement the system, there should be a high dependency unit, and then there should be patients who will be heading straight to theater. And the initial triage nurse will do a maternal history, maternal observations, pain assessments, and fetal auscultation. And if the patient is in labor, they'll need a vaginal examination. The patients are categorized as resuscitative, emergent, urgent, less urgent, and non-urgent. So OTA system is based on the symptom profile of the patient and then their observations. Now you realize that every patient coming to triage, whether you're using BSOTs or OTAs, you need to do symptom assessment, take a brief history, and then you need to do a full set of observations or take the vitals of the patient. So it's, again, I'll emphasize, it's not the color that matters, it's what you do. So if a patient is going to be categorized as red, it's based on their symptom presentation. So if a patient comes in with suspected imminent birth, cord prolapse, no fetal movement, actively seizing, severe respiratory distress, they need to be seen immediately and they will need one-on-one continuous nursing care. So these are patients that should be going into your HD unit or heading into theater, and they need continuous monitoring. If a patient comes in preterm labor, a patient has decreased movements, they need to be reassessed in 15 minutes. So, for example, a patient has come in with decreased fetal movements. Somebody needs to assess this woman immediately after triaging, needs to be put on CTG to make sure. With listening first, put on CTG to make sure this baby has a normal trace, and we try to investigate why this baby has reduced fetal movements. If a woman comes up with symptoms of imminent PET, they need to be assessed immediately by a triage nurse, blood pressures checked, PET bloods taken. And if this patient needs medication like blood pressure control, sulfate, all this has to be done. And they need continuous assessment every 15 minutes. And you realize that OTAS is more stringent than BSOTs because even the lowest categorization of patients in the triage area needs to be assessed every hour. So essentially, we categorize patients based on their symptom review. So the symptoms can be antenatal or postnatal. And so you just look at, let's take the level of bleeding. For example, if a patient comes in with active bleeding, then they are categorized as emergent and they need to be reassessed every 15 minutes under OTA. So that means you should be seeing these patients, sending them to your high dependency area, reassessing them. You should be on a monitor, for instance, be monitoring them. Now, OTAS has some modifiers. So let's say, for example, a patient comes in with active bleeding. If you check and they are in shock, they immediately become red. So the modifiers sort of upstage the level of care that the patient needs. So instead of assessment every 15 minutes, because they are in shock, they've been modified to resuscitative. So you need to do continuous monitoring for this patient. If a patient comes in with respiratory difficulties, and you do their modifiers and the respiratory rate is above 30, they immediately become resuscitative and you need to move them to continuous monitoring in a high dependency area. So if a patient comes in labor and you do a vaginal assessment and they are fully and pushing, they immediately become resuscitative and you need to move them straight into the labor ward for delivery. So these are modifiers of OTAS. So OTAS is another way of assessing patients within your triage area. But in all these things, you need to take a brief history and do a full set of observations. Now there's Muse. So whether the patient is being triaged with OTAS or BSOTs, you need to do a full set of observations. Now you could decide that you would just use Muse as your triaging tool. So based on the set of observations, if the observations are very off or deranged, you see them first. But the problem with doing that is that Muse is just assessing the mother and does not assess the baby. So you probably want to do your OTAS or your BSOTs as your initial triaging tool, and then continuous assessments using Muse, which will either upstage or downstage the patient. So the values of the observations are charted and a summary score is used to determine the kind of level of care the patient needs. So above a certain threshold, medical review and intervention is needed, and the intervention will either reverse or facilitate timely referral. So meals is extremely important. However, we know that no tool actually replaces physical assessments by a doctor. So you're looking at certain physiological variables. So a full set of observations should be done for them at every time, which includes temperature, blood pressure, heart rate, respiratory rates, level of consciousness, urine output, and even you add oxygen saturations in addition to respiratory rate. And level of consciousness, it's easier to use the AVPU system, as GCS calculations can be a bit cumbersome sometimes. So you can implement MUSE in two ways, either by scoring or by looking at the number of patients, the number of variables in red or yellow. So let's look at the first way of implementing MUSE. When you are scoring using MUSE, you do the observations and you give a score based on the level of the observations. So this is a chart for scoring. And let me just point out that if you do not have the means to print a colorful chart like this, you can still use MUSE by scoring. So you can have this on a laminated card that the nurses can hang around their necks, and at the back of it will tell you what actions to take. And so they can calculate the MUSE based on the score, and you can still implement MUSE if you do not have the finances to print this chart. So all women coming through triage will have baseline observations done. And MUSE is important because it helps with early recognition, both at triage and back on the ward, because then you use MUSE for continuous assessment of the patient after you leave triage. And a single score above 3 calls out a cascade. So from moving to every area, and even whilst on the ward, the patient gets assessed frequently. The good thing about MUSE is that it tells you how often the patient should be assessed. So if a patient's observations are normal, then you can do them in 12 hours. If observations about MUSE is about 1 or 2, you can do them 12 hourly, and just continue with your current treatment plan. Now, if a patient is scoring a 3, then they need a medical review. So the important thing to emphasize is if you have a patient scoring a 3 on the ward, don't finish your observations for all the patients before you call a doctor. If a patient is scoring a 3, after you do your MUSE assessment, call a doctor to come and review the patient, wherever the patient is. If this patient is scoring more than 4, inform your senior midwife, call a doctor to come and see the patient. Patients scoring above 6 need the most senior person reviewing them. And as the MUSE score goes higher, we need to be thinking about the BCDE assessment, sepsis assessments for these patients. You can also implement MUSE without scoring, especially if the level of people taking observations, they are not sophisticated enough to be doing these mathematics. So you can just say the number of observations in red, number of observations in yellow, and just use that as a means of implementation. So this is another way of implementing MUSE. And therefore you say, if you have 1 yellow or 2 yellow, so 1 yellow, inform your senior midwife, 2 yellow, inform your senior midwife, and let the house officer on the ward know about these patients. And repeat your observations again within 30 minutes. If you have 1 red observation, or more than 1 red, then you need to get the senior most registrar or resident on the ward coming in to review this patient. And you need to be reviewing this patient more frequently. So that is another implementation pathway for MUSE if you want to use yellow and red instead of the scores or the colors, instead of the scores or calculations. So essentially, when a patient comes through triage, you can use OTAS or BSOTs to triage them to assess the initial level of acuity and order in which they'll be seen. For their continuous assessment, you use MUSE because the observations may be changing and they may be getting worse or they may be getting better. And using MUSE is an objective tool that you can use continuously assess them as they move from the labor ward to the ward to theater. And using meals also tells you how often you should be doing observations for this patient, so that it helps with your surveillance and situational awareness about the physiological state of the patient and whether they are deteriorating or getting better. So this is an example of a patient who's come through maternity assessment unit or pregnancy assessment unit, obstetric ER. So she's been triaged and she's actively bleeding. So on OTAS, you realize that if a patient is actively bleeding, she should be an orange, and that means that she should be reassessed every 15 minutes. But then when you've done the observations, observations are the patient is hypotensive. So on the modifiers of OTAS, they become red. If you use B sorts, they're already red. And then you've also done a Muse scoring. So based on the Muse scoring, you can implement Muse with a score of 8, or you can say the patient has more than 2 observations in red. So they need a senior review and an ongoing plan. This patient has to be in HD. So this is an example of how you implement your triage system and your continuous Muse assessment. Again, when you move the patient on the labor ward, they will have continuous Muse assessment. So when you do the Muse and the Muse is 0, you continue with your plan. If the patient has moved from downstairs or from the maternity assessment unit with a Muse of 0, and now the labor ward, when you do a Muse, the Muse is, let's say, 7, then you know that patient is getting deteriorating, or 2 observations in red, patient is deteriorating. So they need an urgent review now. You do not need to wait and finish all your observations before you come and tell the doctor. You have to inform a doctor or a senior charge person now. Again, if you have a patient on the ward, you can assess them, their meals based on the score or based on the observations in yellow or red, and act appropriately. Thank you.